Kenyatta National Hospital. Welcome to today's session. Yes, David, it is still on, and we appreciate that you found time to attend this session. Jebet Sirma, yes, you'll still get your CPD points. Kindly let us know which cadre so that we can be able to direct you on the appropriate way. But yes, if you're a pharmacist, if you're a doctor, if basically your CPD points have been issued by Daktari Online, yes, you'll still get your CPD points, whether you work in KNH or outside KNH. And so this one you've already. Okay, so today we have Dr. Dorothy Awak from Kenyatta National Hospital, and she's going to take us through medication safety. Thank you, Jebet, for that. Yes, you'll get your CPD points. You'll get your points. This week we are running the Patient Safety Week, and we'll be going through various topics. On 17th of September, we will be celebrating the second International Patient Safety Day, the World Patient Safety Day. That's on Thursday. So we'll be having a series of conversations surrounding issues surrounding patient safety. And we start the conversation today with medication safety. And tomorrow we also have a session on health worker safety. So we welcome you to all the sessions to also understand and learn from us. Sorry, I am echoing. I apologize for that. Let me just see. Okay, let me know if the echo is still there. I hope we've corrected it. Belinda, thank you for that. Let me know if the echo is still there. We'll correct that. So this week, as I said earlier on, we'll be running the Patient Safety Week, and we'll be having various sessions regarding patient safety and other related conversations surrounding safety, both the healthcare worker safety and the patient safety aspect. So join us this week. And as we continue having these conversations, we'd love to hear your experience. We'd love to hear whether you've gotten any challenges at your workplace with regards to safety issues. Today, our conversations on medication safety. So as Dr. Awak is taking us through the conversation, let us know if there are any challenges you experience where you work in with relation to medication safety. And we'll be able to see how to address them and how to be able to find ways to help you wherever you are. Tomorrow we'll be talking about occupational safety and health for the healthcare worker. So that's a conversation. We'd also love to know, do you have occupational safety and health committees in your institutions and organizations? That's a conversation we'd love to have with you and hear from you. With regards to medical errors, I know there are quite a number of sentiments regarding medical errors and the healthcare worker. Medical errors there are many reasons why people don't talk about them. And one of them is that they probably feel that they'll be judged. Their colleagues will look down upon them. But this week, we'd like to urge you to write to us in confidence. You can send your email to us in confidence. Just let us know, share your experience with us. Also share what you went through, because we never talk about what the healthcare worker goes through. If, for example, you give the wrong dose to a patient, the wrong dose of drug to a patient, and something happens to that patient, nobody goes ahead to find out what do you feel about it, what did you experience, and sometimes it's very challenging for the healthcare worker because of the psychological impact and also the emotional impact that they go through. So we'd also love to hear from you if you've ever encountered any error, and what experience. You can write anonymously in the Q&A section or the chat. We will open the chat box. Kindly just share your sentiments about what you went through and areas where you feel as a country we need to improve on in terms of medication safety. So I'd like to hand over to Dr. Dorothy Awak to take us through this conversation. Karibu Daktari.
Thank you very much, Dr. Kalondro, for that kind introduction and also the opportunity to present today to start off this Patient Safety Week. I hope I am audible. Okay, thank you. At least I've confirmed I'm audible. So as Dr. Kalondo has intimated, this is a patient safety week. And to start, sorry, and to try and project. And I'm excited to be able to start us off by just giving the perspective from the pharmacy point of view with regards to medication safety. I hope I can continue to give this presentation without video on so that we can be able to save the bandwidth. That is fine. So, okay. So by way of introduction, my name is Dorothy Iwak. I am a pharmacist. I have, in addition to the undergraduate degree, I have a master's in pharmacology, a master of pharmacy in pharmacoepidemiology and pharmacovigilance from the University of Nairobi. My role in Kenyatta is as a pharmacovigilance lead, among other responsibilities. So for today, this is the outline I'm going to follow for the presentation, just give you an idea what does pharmacovigilance cover, then take you through some of the medication errors we've encountered and let you know what we are doing in regards to handling medication errors, high alert medicines, and other items, and even medicine reconciliation as a way to be able to resolve or reduce medication errors. So I cannot talk about pharmacovigilance without starting with this classic definition, that pharmacovigilance is a science. It's a science and activities which relate to detecting, assessing, understanding, and preventing adverse effects of medicines or any other medicine-related problem from the WHO. The scope of pharmacovigilance is wide. It looks at monitoring the safety and tolerability of medicines, biologics, vaccines, herbal products, cosmetics, so anything that we are going to use, whether it is for treatment, for diagnosis, or something that gets in contact with our bodies or in the process of our work, that we are going to, in pharmacovigilance, we're going to look at how safe is that product and how are you able to tolerate adverse effects or side effects. It also looks at detecting the substandard medicine. So here you will hear us talking about identifying poor quality medicines and reporting them. And in addition, there's the aspect of medication errors, finding out what has gone wrong during the process of delivering care, and looking at also issues regarding lack of efficacy and the off-label use of medicines, particularly now when we are in this COVID pandemic environment where we are utilizing medicines. We did not have anything labeled for COVID use. So it is key at this point to be able to identify if there are any issues regarding safety and even how we are able to tolerate medicines. Now, I'll use this diagram to just give you an idea. What does pharmacovigilance cover? Most of the time we think of it in terms of just ADRs, that's adverse drug reactions and poor quality medicines. But the scope of pharmacovigilance is quite wide. We look at side effects. We know the medicines, even what are the reported side effects. We don't know what would be common in our population. So pharmacovigilance looks at also identifying, encouraging us to report what are the common side effects in our population so that we know how medicines behave with us, among our people. Then also adverse drug reactions. This one I think most people are very familiar with. Medication error reporting. These are in quite a number of facilities, at least have taken up reporting medication errors. The quality issues, this is now when we are talking about a substandard product or a product which has poor therapeutic efficacy. Then there's the other areas which are now in pharmacovigilance, you collect information from use, poisoning, and resistance, which can help you be able to inform policy and come up with regulatory frameworks. Now, if I take you through what would be the outcome of these items, something like side effects, adverse effects, medication errors, quality issues, we say these are going to affect the patient outcome in terms of they can contribute to an adverse event. A medication error or a quality issue can come and now have the outcome of having therapeutic failure. If a patient maybe has an underdose, then they are not going to recover from their condition. And also the aspect of resistance. We say here now, if you have a drug resistance developing, then there'll be therapeutic failure. So if you look at this diagram, what is blue are the areas that are going to contribute to having an to contribute to resulting in therapeutic failure. For the purposes of today, I'll focus on what is on the left now in terms of side effects, adverse effects, medication errors, and quality issues. To ensure that there's a rational and safe use of medicine. It helps us to identify risk factors and possible mechanisms underlying them. Then it gives us an opportunity to be able to assess and communicate the risks of and benefits of medicine. This is why it is important, and want to encourage you to be able to document even the side effects of medications in our population. Then also it helps us to disseminate information needed to improve medicine prescribing and regulation. If I take you back sometime probably last year, when there was the concern on whether patients should use hydrochlorothiazide. So we get information of how medicine behaves in other populations, and we had quite a number of patients who were scared to use the hydrochlorothiazide for fear of them also getting the basal cell carcinoma. But now when we look at that information, we identified the risk groups would be more or less a Caucasian. Those are distinct risk groups. And now from that information, you can be able to educate the patient and let them know whether they actually belong to that risk group. And if at all they're in the risk group, how do you mitigate against that risk? So that brings us now why pharmacovigilance is important to be able to enhance patient education and compliance to therapy. So if you remember the diagram I showed you of the scope of pharmacovigilance, this will just look at some terminology so that we can move together. Like side effects, we want for you to report, we'd encourage you to report side effects, because even if they are known to be related to pharmacological properties, but we want to know what are the common side effects for particular medications in our population. Adverse events, now this one will be an untoward medical occurrence, but may not necessarily relate to the treatment. For example, you give a patient a medication and they fall off the bed. We can't say that maybe paracetamol causes falling off the bed, but because you had given the medication and now something happened, some harm came to the patient, you need to report that. Then the adverse drug reactions, now this will be response which are unintended and occur at the doses normally given, and they have a causal relationship to the drug. So here in adverse drug reactions, when we say we know a drug is suspected. One of the things that we've noted that we are very weak at reporting and identifying is adverse events following immunizations. We know that we need to be able to encourage our population to take up vaccines, to even build confidence in the healthcare programs and facilities, and so that now they can take up vaccines and reduce the risk to the population. But we think whenever we are talking about vaccines, usually there's a lot of negative connotation that you only hear when there's something very negative, like when the polio vaccine and fears of it being related to maybe contamination with either hormonal contraception. But now we want to be able to encourage our healthcare workers and to be able to note if there's any event, whether it is an abnormal lab finding, a symptom, a disease. We want to encourage patients that even when they take the vaccine, we know they're taking it when they are generally well, and they discover that they feel they note something is wrong, you should encourage them to report, so that now we can be able to build evidence of what exactly happens when we give various vaccines. And now we can inform patients so that now we don't have the fears that we have surrounding vaccine programs. The adverse reactions, this one, I think in general, we can say there are those which we know will tend to be common, the type A. They'll be common, predictable, and then there are those which will be unrelated, and maybe unrelated to the medication, rare, severe. But now we need to be able to report both any type of adverse reactions, so that we can be able to know how to handle the patients. So how do we go about reporting these adverse events and adverse events following immunizations? For the ADRs, the adverse drug reactions, they say these the report needs to be having the identifiable patient, what is the reaction, what is the drug you suspect, and who is the reporter, so that you can be able to get this chance to get back to you to find out any other additional information regarding the same. Then you could also make the report electronically. The Pharmacy and Poisons Board has we call it the PVERS, PVERS, the Pharmacovigilance Electronic Reporting System. So you can create an account for your facility or encounter an adverse drug reaction, you can be able to go online and make that report. And that one goes directly to the board. The report, if you go online, this is how the yellow form is what we use to report the adverse drug reactions. It looks very similar to the hard copy form. So if you're familiar with the hard copy form, then it is going to be fairly easy to also fill the electronic form. And now what happens after you've completed, you've reported an adverse event? You need to be able to go back now and see, now to ensure that this does not recur again to the patient, a patient needs to be given an adverse drug reaction alert card. And now the patients who get this are the ones who tend to develop near fatal reactions. They have a drug-induced morbidity, or maybe a hospital admission, they required hospital admission as a result of this adverse drug reaction. It's important that we complete the loop, that once you've identified the ADR, you need to have the patient notified what it is they reacted to so that they are not exposed to the same ADR in the future. And want to encourage the patient, this is usually a pocket-sized card, to carry the card when they visit the healthcare facility. When you're looking at vaccines, the immunization program, there is a specific tool for reporting the adverse events which follow immunization. And when this is documented, it's a bit more complex, but it borrows similarly from the yellow form. Then usually an investigation is conducted to find out what would be the reason behind why we had that adverse event. Remember, again, we want to encourage reporting, because this is one way of being able to identify gaps in the system and even get new knowledge that can help us to improve patient care. Besides now what can happen to the patient in terms of a reaction, we could also have incidences of having poor quality medicines. And the same way, the board also has a distinct tool for being able to report this. We call this the pink form. So you use it to report any quality complaints that you have regarding a particular medication. And it is not limited what kind, even we can report cosmetics on the same form. So we report and then we can be able to take action. In Kenyatta, when we find that there is a gross we note that a product, there's a complaint about a product, we can be able to check what is the nature of the complaint. Sometimes they are batch related, and therefore when a batch is replaced, you find the same does not occur. Or you find the product, maybe it's some contamination and we're required to withdraw it from all the clinical areas. And this we have been able to do at KNH and also working with the board. Now I want to spend a little more time looking at medication errors, because these ones are what we tend to come into contact with a lot more as we interact with patients, as we practice, as we even engage with each other. So what is a medication error? It's a preventable event. It can lead to patient harm while the medicine is in the control of the healthcare professional, the patient, or the consumer. And now we say medication errors are part of drug-related problems. So what kind of errors have we encountered here in Kenyatta? So in KNH, we have as distinct a standard form that we use to report the errors that we come across. I hope it is fairly visible on your screen. I think other facilities could have maybe an electronic tool to do the same, and we're also looking into also reporting our medication errors in an electronic format. So this, what you're seeing on the screen, is an example of an error where one of my colleagues noted that we had received a prescription. You can see a prescription, for me it is to my right. You can see the prescription where we have Celebrex 200 milligram BD prescribed, but there's no duration. So what did you do? You identify that there's a problem, there's no duration noted there. So that is an error you capture, and you can see on this form you capture what is the type of the error, what is the medication incident. Then we describe what are the facts of the incident and what did the person do. Because we say you don't just identify an error and do nothing, you take action. So what this colleague did, he referred the patient back to the prescriber so that a duration can be indicated, and then now that was done. We also have errors which are resulting from prescription books. On the inner face of the prescription books, there is clear instructions of how it is the prescription is expected to be filled. So an example that you can see here is like for the example of the narcotics, guidelines indicate that this needs to be prescribed fully in words, and including the dose, the strength, the duration, all that needs to be written in words and on a separate prescription from other medication. So you can see here the prescriber, yes, put it on a separate prescription from others. This actually was an error we just encountered also today, but it is not in words. So the problem of not writing prescriptions for narcotics in words is that it is prone to being abused. It's very easy for someone to decide to change this 30 to 60 to 90 to any figure or even 180. And we know now we want to reduce the likelihood of abuse. Remember, we say that in pharmacovigilance, one of the items we are looking, one of the areas we look at is drug abuse, looking at drug dependence and misuse of drugs. So we report this, we document this as an error, and we also take action, referring back to the prescriber and reminding them that they need to adhere to the guidelines so that we can avoid an untoward effect to the patient. So looking at what it is we have been able to capture with these, the tools that we already have in place. Majority of the errors we have captured as a division is related to prescribing. Now, this is not to say that the only errors that we capture are prescribing errors. So I need to take this in context, because you notice that it is easy to capture prescribing errors because it's documented, prescribing and even transcribing errors. But dispensing, administration, monitoring errors, those ones heavily depend on being able to observe that the error has occurred, and then having now somebody report that this error has occurred. But so now in this diagram, you can erroneously think that the only errors we encounter is prescribing, but it's because these are errors which are very easy to capture from documentation. But now I'm hoping that going forward, we are going to be keen to even look at other errors. I want to think that because we are capturing it at pharmacy level, our focus is very heavy on prescribing. So I encourage, if there are health workers in other, whether it's in nursing, as the clinicians, to also check us as the pharmacy people. Are we making dispensing errors, and also document and report them so that we can be able to learn from our mistakes? What kind of errors, what kind of drugs are involved in this? Have we been able to capture? We've basically gotten drugs from literally all the categories of medication. So from this diagram, you can see most of the errors we capture relate to antibiotics, the anti-cancer medicines, analgesics, anticonvulsants. So we have a whole range of medications that we have been able to report with regards to medication errors. What types of incidents? There are a whole range of incidences, from incorrect dose, omission of the duration of treatment, like the prescription I showed you earlier, indicating the wrong strength, omitting the frequency, incorrect duration of treatment, having no indication, omission of drug strength. You see now, for example, maybe you can have a medication like sodium valproate. We know it has various strengths. Then we just have a prescription of sodium valproate and then BD. So that one will look unusual, but we have encountered a number of prescriptions where you have a drug which could even have multiple strengths, but you don't have the strength indicated for that prescription. So what do we need to do to ensure that we don't have, we can be able to address such errors? We want to encourage the use of implementing the 5 R's, the 5 rights of medicine administration. So here we're saying we need to make sure that we have gotten the right patient. I know a long time back Kenyatta was in the press for taking the wrong patient to theater, but sometimes even we have the wrong patient, the patients having similar names. Considering our location, we have patients who maybe we have 3 Mary Wanjiros who have come to pharmacy at the same time. So we need to make sure that we have identified actually the right patient. We give them the right drug at the right dose, at the right time, and we're using the right route. We know we have drugs which have different come in different formulations, so it can be an injectable, an oral, the pessary, suppositories. We need to make sure we've identified the right one, and we need to communicate very clearly to each other as healthcare workers what is it that we intend to have the patient take. That means the prescription needs to be clear so that the pharmacy personnel can be able to
Sorry, we apologize for the network challenges. We're just going to get Dr. Iwak another device very fast. Give us a few seconds.
I want to hope that the device has come back on. So let me take us back to where we were. So if I confirm that we are where we stopped, so apologies for that. So what happens when we, okay, so I'm hoping you're looking at the slide errors and ADRs. So what happens when we have a medication error? For example, not being able to communicate clearly to a patient how they're supposed to use a medication. An example we've had in our circles is the use of the chlorhexidine gel. Now this, before now for cleaning for cord care, a lot of time we've been using the disinfectants, some others maybe are told to clean with the gel, but now studies had shown that using chlorhexidine gel will offer much better results. Communicated very clearly to the parent or to the caregiver how it is given, you end up having the patient being given the medication in the wrong route. So for the scenario for this child, the gel was applied as an eye drop, and now that exposed. So we have to ensure that during medicine, we should not take lightly how it is we, it shows the connection is unstable. Well, I'm wanting to hope that you can still follow. But if we're not communicating clearly, then there's a chance that the patient will use the medication in the wrong way, as the case in this scenario. Then also explaining that who is the medication intended for. We have the challenge that you go home with medicine, you don't finish it, so you decide to keep it for the next time or for somebody else who might have a similar complaint. And anything we see in a dropper might be confused for being an eye drop. So for this gel, some of them were packaged as in dropper bottles, and some of the population confused it for an eye drop. And now, anytime somebody is unwell and they think maybe there's a problem with their eye, and then they use the wrong item. So I want to encourage clear communication is important. Now, as much as our reports did not capture as many dispensing and administration errors, and this I said is not because they do not happen. They happen, they may happen even at the same frequency, but the challenge has been that these are errors that you will note from observation, and therefore if we don't encourage each other to report this, then we are not able to note what errors we have. So how come we tend, what causes some of these errors to occur? One of the things we found is the challenge of look-alike and sound-alike medicines. Now, for what is on the screen, it is actually not a black and white picture. These eye drops had this color, and now they look quite similar, without any distinguishing feature like a label, a cautionary label to let you know that you need to check. You might accidentally maybe dispense atropine. And if you don't have somebody else to double check you, then you double check yourself so that you can make sure you don't give the wrong item. Then we have other products that, for example, diazepam, neostigmine, furosemide. I know we have a whole range of products from Cosmos that the packaging looks quite similar. And now these are occasions which increase the likelihood of you dispensing or administering the wrong medication. So the clinician would have done the right job to identify the right product, but now we give the wrong product because it looks similar to another one, and now we need to be vigilant and cautious and look at what is in our environment and try and reduce errors. So what are we doing in Kenyatta to reduce the likelihood of dispensing the wrong drug? We have cautionary labels, which will guide us like how is a product supposed to be stored, so that if something is supposed to maintain cold chain, that we keep it refrigerated. And for those which look alike, we have these labels. They look alike, sound alike labels. The purpose of these labels is to be able to alert our staff that there's a chance that you could be picking the wrong item, and therefore you just need to confirm. So anytime we have products like what you've seen above, then we affix the look-alike, sound-alike label as a trigger for each other to be able to counter-check that we have actually picked the right product. Then we have other medications that we are going to talk about, which are the high alert medicines. Now, these are the ones which, in case of an error, then you know that there's likely to be significant harm that comes to the patient. So we have the same cautionary labels to be able to warn whether it is when it is cytotoxic medication or just a high alert, other high alert medicine, which we will look at as we go on. So, like I said, high alert medicines, these are those which bear a heightened risk of causing significant patient harm when used in error. The top 5 harms, there is the insulin, the opioids, the injectable potassium solution, whether it is chloride or phosphate, intravenous anticoagulants, and highly concentrated sodium chloride solutions. Now, these are not all the harms, but these are the ones which you find most of the errors. We say the top 5 harms are the ones which most of the errors reported related to high alert medicine are involving drugs of this class. So I hope that going forward, we're going to be keen. We know we probably might be handling diabetic patients, so we'll look at the medicines, or we may be having patients who are on heparin therapy. So we need to be very careful at the point of dispensing, administering these medicines. So in KNH, we have circulated to all the clinical areas and pharmacies. This list I know might not be very clear to you, but you can be able to access a list of high alert medicines from the Institute of Safe Medicine Practices. But we have customized the list to identify what are the drugs that are in the high alert medicine list. And if I could just read for you, we have now the intravenous adrenergic agonists such as epinephrine, we have the labetalol, we have antiarrhythmic drugs, we have antithrombotic agents, the hypertonic solutions, cytotoxics, liposomal forms of drugs. There's a whole range of medicines that fall in this category. And now what this list is to do is to prompt us to be cautious, double check the dose, triple check, try and reduce distractions when you're handling this medicine. So what we do in practice here in KNH, when we have the medicines in different strengths, then we keep encouraging ourselves to double check, make sure that you're giving the right strength of that medicine. See, like for anticoagulants, the low molecular weight enoxaparin, it comes in different strengths. We have the 20, 40, 60, 80. You need to be cautious what strength was prescribed and what strength are you issuing or administering. And whenever we have a new medicine procured on tender, then staff need to be alerted and educated on safety concerns regarding that medication. So in our high alert list, we have these strategies that appear at the bottom of the list, where we expect that for any medicine which is identified as a high alert, then we affix that label. And when it comes to prescribing, you discourage the use of initials. So you don't have insulin like 10U or IU. We'll encourage that it's prescribed as 10 units so that we don't have confusion of dosages. And for where, as much as possible, where you have the resources, if the pharmacy can send out to the clinical area already ready to use infusions so that you reduce the likelihood of it being prepared in the wrong way. So now with that, I want us to come to what do we do to ensure that we reduce the risk of medication errors. So here, and how do we bring in the patients to be able to support patient safety? So we have like the 5 moments of hand hygiene, we have the 5 moments of medication safety. So here we need to encourage ourselves and even the patients to be thinking at the point when they're starting their medication, when they're taking their medication, adding a new medication, when there's reviewing of the medication, when they're stopping medication, you need to be checking, is this the 5 hours? Is it the right patient, right time, right dose? We need to be looking through to ensure that we don't have ourselves or expose the patient to the wrong treatment. So one of the things we have started to do in KNH is, to a small way, is medication reconciliation. Now, what is medication reconciliation? We need to know that the patients, when they're coming to our health facilities, or if they are those in private practice, then they're coming from maybe home, let's say home to be admitted. And when they are at home, there were medications they were on. At the point of admission, do they tell you all the medicines that they were taking? Then when they're leaving the hospital to be sent home, have you been able to reconcile and know what it is they were given in the wards and what do they need to go home with? You know, sometimes the patients are admitted, they don't tell you what medications they have been taking at home. So when somebody comes to visit them, they bring them probably the enalapril that they had at home, and here in the ward, we are giving them another enalapril. So we say we are having the patient having duplicate therapy. Or maybe a medication was stopped because of an adverse effect. But since the patient doesn't know that, they still take their medicines from home, and we are giving them a different medication. So what medicine reconciliation allows is for you to be able to go through and get from the patient or family interview, identify all the medicines that the patient has been taking, including if they have come with some of their medicines with them. You document everything that they have been on. If that's an old patient of your facility, look at the previous health records. What medications had they been on? And then you give the the best possible medication history. What medicines have they been on? Are they still ongoing? Has it been stopped? And then now the healthcare facility see, do you need does the patient stop? And at the point of discharge, treatment were they on? If they were on an antibiotic that was just supposed to be 5 days, and then now they stop the treatment, do they go home and they start telling the one of their caregivers, maybe if it is an elderly patient, they say, oh, I was taking amoxicillin in the ward, go get me some more, because the whole time they were they were under care, they were familiar with particular medications. So we need to make sure that even at the point of discharge, we give also the best possible medication discharge plan, so that now when they keep on getting through the cycle of care, they are aware what were they taking, does it need to continue, and even as we transition from one care provider to another. Say like in the scenario in Kenyatta, patient can be going to cardiology clinic, then they go to CCC clinic, then they go to maybe orthopedic. So we need to make sure that the patient has a clear idea of a clear plan of what it is they are taking, and that one can help the healthcare provider. So this is just the definition of medication reconciliation. It's creating the most accurate list possible of all the medication the patient is taking, including the drug name, the dose, the frequency, and comparing that with the list of what the physician has given during admission, transfer, or discharge to ensure that they actually have the correct medications at all transition points. So when they are getting to the ward, they're having the right medicines. When they are going home, it's the right medicine. When they're visiting various clinics, we're having the right medicine. So what tools do we have in KNH to be able to facilitate this? We have designed we call it a medication therapy management form, where one of the things that is captured is a list of all the current medications they are on. And in case it stopped, then that is documented. And the reason for either use of stopping is written there, so that now the patient, if the patient, the clinician, as they're seeing the patient, they can be able to see whether the treatment was stopped or it needed to continue, and you can be able to identify problems from this list. So part of the form also has what problems are there that need to be resolved. If you find there's duplicate therapy, you indicate it, document. Remember that if you don't document, say what you don't document doesn't get done. So you need to document so that you can be able to share with the other members of the healthcare team what problem you identified, and so now you work together with the rest of the team to make sure that you resolve this problem. So what have we been able to achieve using our medication therapy management service? We started this in the last financial year, and now we're able to identify some challenges which are either related to the system that we have, the healthcare system, or the patient. Like we realized that from just interacting with the patients before they go receive their prescriptions, we find there are a number of them. For this service, I need to say we have implemented it so far only at the endocrinology clinic, where our diabetic problems we've been able to identify is that the patients are not monitoring their blood glucose. Some of them also fail to renew their prescriptions on time. That means that it has an effect on adherence. So there may be and things that it is not working, and yet it is the patient who maybe for a financial reason they were not able to come and collect their medicine. Also, we notice that as you talk to the patient, there are those who are actually unable to self-administer the correct insulin doses. So you have to, at that point, you identify using the syringe, and different device, maybe like a pen device would be better for the patient to be able to accurately measure their dose. Also, some who don't have a clear understanding of the correct timing of medicine. And then we notice that we know that diabetic retinopathy is also a risk among our patients. And so sometimes the way we label instructions, we need to be clear that we are sure that they can understand them. So we find some of the patients have actually not been able to read the instructions we put on the labels, and they try to use memory to try and figure out how it is they're supposed to use the medicine. We also notice that also on our side, we have been inconsistent in supplying of oral hypoglycemic agents or newer agents for management. And so now, therefore, as a division, we look at how do we improve on our end so that we cannot have, we can reduce the challenges. So I come to the end and just say, what can we do? Basically, from what it is I have been sharing about. My apologies. It looks like network is not favoring me, but that was, we're getting to the last slide. So if I just get back to that slide, we're getting to the end of the presentation. So as I was saying, it is important that we communicate clearly. I want to hope that you can see the right slide. So it is important that we communicate clearly to each other, to the caregivers, so that we don't have an error. And as I had given you the example before with the chlorhexidine gel, that an error that can lead to a significant adverse effect. And we need to encourage the patients and their support system to know that they're also part of this communication chain. They need to tell us what it is that whether they are understanding. Are they be able to understand the instructions we are giving them? What challenges might they be having, so that now we are taking up a patient-centric approach. Then the organizational culture. We want to encourage as much as possible that we report errors. I gave you the errors that have we've been able to collect, mainly relate to prescribing, not because that those in our facilities only prescribers who make errors, but those are the ones we are able to capture from the documents. We need to be able to encourage each other that even when you yourself make a mistake and you're the head of that unit, you need to be able to document it so that it can be able to, we can use that as an opportunity to learn. So we document to be able to use errors, which whether they actually occurred or a near miss. You are about to pick losartan H when you actually intended to pick losartan. You document it so that everyone knows that there's a chance you can confuse the two drugs, and therefore you need to be cautious. And now we can put in a system like what we have in place, the look-alike, sound-alike labels, and even just by engaging each other. When you tell somebody, do you know the furosemide and diazepam that we have now looks the same, I was about to give the wrong item. So when we do that, we encourage each other to be able to look out to be able to, as a stopgap measure, to ensure that we reduce the likelihood of errors. And when an error occurs, then we need to be able to address it not in a punitive way, but to say we adopt a just culture. What is the reason behind the error, and what is key? Because leadership shapes the culture that you have for the organization. So when we have our leaders who inspire the staff to continue to strive for the highest quality of care by using safe and effective methods. So here we're saying we want to encourage our leaders, the leadership, even yourself as you consider yourself a leader, that you make sure that you let your team know that yes, errors can happen. Let's use the errors as a way of growing, and now make it clear that it's a priority to look at patient safety issues, and motivate staff to be able to to be part of the patient safety team. And I think I'd like to say that brings me to the end of the presentation, and possibly we could take a few questions.
Thank you. Thank you, Dr. Iwak, for that wonderful presentation. Thank you for that wonderful presentation. You were very clear. We apologize for the network challenges we had, the drop-in once and off. We apologize for that. So Dr. Iwak, I wanted to ask you a few questions before we come to the Q&A section. I'm seeing there are a few comments in the chat from a few of our colleagues, and also we have a few questions in the Q&A section. Questions on CPD, I will address them at the end. Please bear with us. We will address your questions about CPD points at the end. So what is the uptake of these reporting systems, especially the one for the PPB, the one for adverse drug reaction alert? And there's the electronic form, there's a manual form. I know you're probably not very, you may not know a lot about the PPB and how it works, but it'd be good to hear, are people reporting, are they self-reporting? And are we able to get that information and data to improve and learn from it as a country? And if there's also anyone from PPB or anyone who's close who might have that information, kindly let us in the Q&A section, the uptake of both the electronic and the manual form. Are people reporting? Yes, Dr. Iwak.
Okay, thank you very much, Dr. Kalondu. In KNH, within the Division of Pharmacy, it is one of the targets that we have to, on a monthly basis, to document, to report errors, poor quality medicines, ADRs. So we find within the pharmacy, because it is a target, then we find that it is the uptake of the form is good. But we are finding we are reporting a lot more medication errors, which we were happy about, that people are a bit more vigilant. Now, with regarding to ADRs, this one, it's the identification has been quite poor. Maybe somebody identifies an ADRs, but they don't document. So we might not find as many people documenting ADRs, and you might encounter them maybe when a patient comes for a refill and they tell you, I stopped using that drug because something happened. So you ask, was it ever reported? Do you have a card to make sure that that doesn't happen? And you find that maybe the patient didn't know or it was not reported, but it has actually improved over time. We are finding our staff are quite keen to be able to document errors. Now what we need, we are working on is making sure that the patients actually live with an alert card, so that now we don't have the same, we can break that cycle of them being exposed to the same risk. I think in terms of the board, most practitioners, or at least most pharmacy personnel, may be already familiar with the electronic reporting tools. So I think there's quite a good uptake. I think there are even counties which summarize their reports, and the Pharmacy and Poisons Board routinely sends newsletters to give you an idea what are the numbers of reports that they are receiving, what are they seeing in the field, and they communicate the same to us through newsletters. So I think the uptake is good, but still, because the form, I know we did not go through filling it, but anytime that somebody fills a lot of boxes to check or details to put in, then there's that inertia to document. But otherwise, we are seeing that there's improved uptake of the form.
Okay, thank you, Dr. Iwak, for that response. And I agree with you. Reporting is a challenge for most of the errors that occur, not just medication errors, but also clinical errors that occur. And what happens is the patient gets affected. The patient experience, they're not satisfied with the service that we give once they get an adverse drug reaction and we don't take action towards it. The cost of care it increases, because if I get an allergic reaction or an adverse reaction to this, then now I have to incur another cost to treat now that adverse drug reaction. And also some of them go through physical and psychological pain, and also the lack of trust in the healthcare system. So it is very important that we report and learn from the errors that occur, so that we're able to build the culture and also make the patient to trust us as a healthcare system. And some of the highlights that you highlighted when you're talking about medication therapy management is that some of the challenges that the patient has is that they fail to monitor their blood glucose, they fail to renew their prescriptions on time. That patient information is what is clearly lacking sometimes as we give our instructions or sometimes as we prescribe. And this is both a clinician aspect, the doctor's aspect, and also to some extent, maybe the pharmacist side. So communication, as you brought it out very clearly, is very, very important in reducing these errors and preventing them. And it's something that we need to embrace. So we'll have a session on communication probably sometime next month, just to get to understand how do we communicate to our patients and get to hear the patient's perspective. Now, when we go to the Q&A section, I'll start with the first one where somebody is asking, how do we monitor adverse effects related to IV contrast? Is there a special tool for IV contrast, or is that reported under radiation safety?
Say the tool for reporting adverse drug reactions is any product you use, even the IV contrast. So anything we're using for treatment, for diagnosis, for prophylaxis, as long as we are using it in the healthcare system, you report it with this very same tool. The only tool that is for reporting in terms of adverse effects that is different is when it comes to immunization. That is only on which is a different tool, but all other things, including even cosmetics, you report with them with the same adverse drug reaction tool.
Okay, thank you for that. And somebody is also seeking clarification. Is there a difference between adverse drug reaction and an allergy, or are they the same? When a patient says I'm allergic to sulfur, is it their interpretation that they had an adverse drug reaction to a drug that contained sulfur and now they're referring to it as an allergy, or are these two different status that you're having? And that also goes to the second question to the next question by Boniface Njiru, who's saying, can a patient who never had hypersensitivity to a specific medication before 13 years of age start getting the reactions when they're older? So adverse drug reaction and allergies, are they the same thing?
I want to say that they are the same. Somebody else can tell me different, but when you have an adverse, you are allergic to that medication. So you treat them the same. If you're allergic, you've had something happen to you, it could be the severity is what would differ. That maybe when you're allergic to something, will you be given an antihistamine to allow you to tolerate it? Will you desensitize you so that you can take the treatment if you have to? Or do we need to make sure that you don't get the treatment? So an allergy would be there. When you're allergic to something, you're allergic to it because you suffer adversely when you're exposed to it. I hope that is clear. The second question, I think, needs to be repeated.
No, the second question was about a 13-year-old who's getting a reaction and after being exposed to a drug, and he's never had that similar reaction before. But it's also related to the answer that you've just given. So thank you for that. There's a comment in the chat box and somebody saying at KNH, you're doing well with this initiative. What about the community pharmacies where most patients appear first? So I'd like to hear from the participants where you work. Are the community pharmacists, are the chemists that you're working in? Whenever you get an over-the-counter prescription or even just a verbal prescription from a patient, are you able to report? Is there a system for reporting a medication error that you encounter? If it is an over-the-counter prescription, are you able to report maybe prescription errors that you encounter, or if any drug interaction, a patient was given a drug in another hospital, they've come as an emergency at night, they're having a reaction to it. Do we just issue them with antihistamines, or do we have a system that we report? So we'd love to hear about that. How do you report at the community level and whichever chemist that you're working with? There's feedback from Lawrence Okongo, and he's saying, thank you for this very nice presentation. 2 points I want to highlight. The first one is use of inhaler devices is poor among many patients who therefore suffer uncontrolled asthma. We should improve on our own skills and patient skills on use of inhaler devices. That is true. The second one is on vaccine, and is talking about reporting of adverse events following immunization has been very poor, partly due to ignorance on reporting channels. This could be clarified further. We'd encourage all to report vaccine adverse events following immunizations so as to improve communication on vaccine issues. And that's the same feedback that we got from Dr. Awak, that the reporting for vaccine, adverse events following immunization has been very low. People have not embraced it very well. And thank you for that. So from Philip Mushiri is asking, how do you achieve good cooperation with the prescribers to enable smooth reporting on pharmacovigilance?
Thank you, Philip, for that question. Say a journey of 1,000 miles, I think, starts with one step. So you just keep communicating, and I'm glad that the research and programs will plan a session on communication. When you're communicating, it's not say you have done, the tone that we use when we are interacting with the prescribers, we will be able to guide you on how well they receive your message. So if we find an error in a prescription and then we just call the prescriber, you're wrong. No, we need to be able to introduce yourself, explain. So it has been a journey, because initially when you'd identify errors and seek clarification, some don't perceive it very well. But over time, as you keep on being persistent, as you also work on how you communicate the issue, and you also explain to the patient in a way that you also maintain the confidence of the healthcare worker. Don't tell them, I hope most people understand Kiswahili, but say, sasa huyu daktari alikuwa anaandika nini? You need to be able to communicate to the patient in a way that you're going to make sure you maintain that confidence. Say, I noticed we need a clarification on this prescription. This is not quite clear. We're not familiar with this. So, or this does not, we are not used to dispensing this item in a certain way. So I need you to be able to go back to the clinic or walk back with the patient. Like for the MTM service, we encourage the pharmacy staff there to actually walk with the patient to the clinician and explain what is the problem. But in the outpatient setting, because it tends to be very busy, you need to indicate on the note very clearly what is it that you require clarified. Like the prescription which I showed, we needed the duration indicated. So the way you communicate the patient, so they go back and seek clarification, or you yourself walk to the patient or contact the prescriber themselves if you have access to their contacts, is what is going to be able to help you get buy-in from prescribers. Remember, even you don't want to be asked, Sasa, what is this that you dispensed? You don't know how to read the prescription. So it is communication is key. How you communicate is what is going to determine your success.
Thank you, Dr. I can agree with you. How you communicate is what is going to determine your success. And the next question comes from Francis. And I think this is a very common scenario that we encounter. So a client comes to your facility, gets medication. The prescription and medication is dispensed and they're totally correct. On taking the drug, the patient experiences a case that needs to be noted as far as pharmacovigilance is concerned. However, the client goes to another hospital facility with the assumption that he or she was given the wrong medicine. On the other facility, the medic goes ahead and treats the patient afresh. How can this case be handled? Because this is a common scenario whereby if I get a service which I feel my experience was not good when I came to Kenyatta, now I'll go to Mama Lucy, and instead of that reporting system coming back, the feedback from the facilities, between the two facilities, or even the patient just coming back to tell me, I was not happy, the medication you gave me, this is the effect that I got from it. How do we handle such cases so that that can be reported and the patient can be made alert that this is what you're suffering from?
Okay, there are quite a number of ways we can be able to handle that. For starters, when you're aware of the possible side effects of a medicine, then you need to be able to alert the patient. Also, at the point of dispensing, you need to ask, we usually just say, do you know how to take these medicines? Just take them. We need to be asking them, have you ever taken this medicine? And in case you experience a problem, in case you have an allergy, because we don't know how the medicine will behave, you need to be able to report back. And then again, see, towards the end, I talked about the best possible medication history. So along with the medication, because patients can lose the box or the envelope, if we can send patients with the list of all the medicines they are on, so that even when they leave Kenyatta to go to Mama Lucy, they are aware what medicines they were taken. And then now you can be able to, we want to also encourage teamwork among facilities. Like, for example, with the hospitals, when we talk to each other, we say we have encountered a patient who reacted this way. Let's say we have a group of pharmacovigilance specialists. And so when somebody encounters a reaction in their facility, they tend to post in that group, and it is from that group that we learn that this can happen. So sometimes you find that the patient who has been, someone has shared maybe from Kiambu, had actually passed through KNH, and it's an opportunity to be able to learn and share and say, okay, fine. Now you've identified that there could be an adverse drug reaction, but also letting the patient know that when they suffer that, they need to have a card. And now the next place they go, We want to reduce the risk that they're exposed to the same agent. So communicating the effective medication use counseling and letting them know you may not list out all the side effects that they have, but you need to give a rider to the patient that should you not feel any better, or should you have experienced something that is unexpected, that you need to come back to the health facility so that we can address the issue. Or you need to report that then if you feel you don't have confidence in Kenyatta, you need to report that at the next facility. I took these medicines and this is what happened. Because you might find, you might land there and you're given the same medicine, maybe it's as an injectable or the brand is different and they are not aware. So patient education is key, and documenting, making sure that the patient is always aware what it is they are allergic to, if they have mentioned or you have identified an drug reaction.
Thank you. Thank you, Dr. Iwak. And I just wanted to ask, do we have systems that can detect when we erroneously dispense the wrong medication? And this is from Jennifer Orwa. And she's saying, occasionally the pharmacist can erroneously dispense the wrong medication. How can this be detected unless the patient comes back to complain with a complaint? So in facilities where we don't have an electronic system, where we are usually using prescriptions like the way we do in Kenyatta, do we have mechanisms in which we can be able to detect that?
Okay, thank you very much. That is Professor Orwa. We encourage double check. So in the pharmacies within Kenyatta, we say you don't dispense what you packed. As much as possible, if you pack the medicine, you're not the same person who dispenses. So we use a chain so that way you can be able to check each other. And should you be in a situation like if I think in a community pharmacy and you're alone, you want to encourage a triangle check. Look what is on the prescription, what it is have you collected, what is the medicine that you've picked, and then what is the label you've written. You'd rather even look at it 3 times and delay the queue, because I know many times if it's a busy place, there's a haste to serve the clients and they go away. But you'd rather to do a triple check. What does the prescription say? What drug have you picked? What label have you written? So that you can be able to physically check. But otherwise, we also don't have an electronic system of dispensing, but you can also print out the label, but what you fix the label on the wrong item. So that is the way we've been able to manage it, but also the reporting. When we make each other aware, like now when we realize we have brands of medicine that are very similar and therefore there's a risk, when we post it on our forums, on our various forums, it makes us more, it increases our awareness. And then when it is medicine, we are giving it to the wards, then we encourage the nurses, before they go with the medicine, they need to check what is it that they are giving. Because if you have one person in that whole medicine use chain doing everything, then there's likelihood of mistake is higher. But when you keep, say, have different actors at various processes, then that is easier. And also when we are dispensing medicine, we ask the patient, is that what you are taking? Sometimes the brand has changed, so you need to just let them know that the brand is different. Maybe it is Cabedilol, a brand Kaka, and now they're having a Vidol, and they go home and maybe they have Kaka at home and you send them home with Vidol. So you need to let them know what is the name, the actual name of the medicine, so that even the patient themselves can tell you, I don't think this is what I've been taking before. Thank you.
Thank you, Dr. Iwak. And this is from Dr. Christabel Kaimba from PPB, and she's saying, yes, we receive both the manual and electronic forms. About 90% of the reports are sent electronically. We also send out newsletters and 2-pager reports. So participants can send in their email. Please look at the Q&A section. You'll get the email for pharmacovigilance unit at the PPB, so that you can be added to the mailing list, and also to report, that is the same place to also send your reports. The email addresses are in the Q&A section. And this, I believe this responds to your question, David Dishu. You're asking whether you can use pharmacovigilance, electronic pharmacovigilance forms in non-pharmaceuticals. Yes, I believe you can, but reach out to Christabel Kaimba, Dr. Christabel Kaimba, for more information on how to go about that and how to access the tools. There's a question. There's somebody who's asking about how we manage delayed reaction as far as pharmacovigilance is concerned. How often do we get delayed reactions, and is it still a pharmacovigilance issue that needs to be reported, or is there a time frame for the reporting to be done?
whether a reaction is instant, delayed, whatever reaction, as long as it's a reaction, you report it. We say even if you remember you had a reaction 1 month ago, report it, because it builds to the knowledge, because it helps the board also identify how is our population responding to treatment. Then also, if we find that most patients have an adverse reaction maybe to a particular drug, if I give an example, the amlodipine, we have a number of renal patients who say when they take a certain type of amlodipine, not remember my chemistry very well, but the isomer forms. So for some patients, they find that they have an adverse reaction when they are on one isomer of amlodipine, but they don't feel the same on a different one. So if we find that the reactions are common, maybe at that point now the regulator can say, now in this market, because we have a big population of patients who respond negatively to a particular isomer, we will only be registering this brand, not this brand, but this form of the drug, because it has a better safety profile. So whether it is delayed, it does not matter the time, as long as you've identified a reaction. Sometimes a patient comes for a refill, and that's the time when they tell us they had a reaction the last month. We still get their details at that point and document, because we know it is going to build to the knowledge and help protect them in future or others, because now it makes you aware. The next time you're dispensing a medicine, you're going to ask, have you ever had a reaction to this? Or you'll be saying, in case you start feeling maybe weakness, and the like, you need to be able to know that it could be as a result of the medicine, and you need to come back to the healthcare facility. Thank you.
Thank you for that response. And I believe that answers Abraham's question. Abraham was asking, from the new drug reactions and side effects that haven't been detailed in the past and have just been discovered and reported, do we have a standard avenue of relaying this information back to the prescribers and the dispensers? So is there a feedback mechanism for relaying this information back to the doctor who prescribed or the...
Okay, most of the time getting back to the chemist, if it's a chemist which dispense, getting back to the chemist has been a challenge. So I'm hoping that from this session that we'll be able to communicate with each other, but we rely mainly if you can sign up with we call it e-shots from the Pharmacy and Poisons Board. You get a newsletter which gives you a highlight of the drug reaction side effects which have been reported. But with prescribers within our setting, when we identify a reaction or the side effect, or a patient complains about a side effect, particularly in the clinic where you run the MTM service, you walk back with the patient to the prescriber. But for those who are who are visiting our other outpatient clinics, then now you will will indicate on the prescription that they need to go back to the doctor who saw them to attend to the issue or to note the issue, and then you write for them and you issue them an alert card. We've been having challenges with the alert card, but you issue them an alert card, and now at that point you take that time to empower the patient, communicate to them that when you have this, when you take this medication, this is what happened. So you need to communicate to the doctor. This is a training institution, so it might be a different doctor who sees them at the next appointment. I see for our cancer treatment center, patients have like a duplicate file, which they carry around as they visit different care areas, so that now at least they have some background of what investigations they have had. So now that card, alert card, or even when we give them we call it the personal medication record, and you indicate this medicine, this is what happened, that's why it was stopped. They may not remember that amlodipine or losartan gave me a problem, but if they carry their paper around which has the medicine they have taken, it's a way which we are able to communicate back, because sometimes by the time the patient comes to the pharmacy, the clinic is over. So we can't find the same prescriber. But when we are in forums where we are with the other prescribers, and we can be able to share, or even like this forum that we're having today, then we share what it is that we have been able to collect or identify, hoping that also through the Medicine and Therapeutics Committee members, they can share that out. They can be champions to share that out in their various specialties or the areas they work in. Thank you.
Okay, thank you. Thank you for that response, Dr. Iwak. There's a comment from Arifa. She's saying, I work in a private hospital. We do have adverse reporting tools, but prescribers never inform us of any adverse reaction. Another comment from Zephania, and they say, NICLA pharmacy reports to prescribers of prescription and sends back the patient to the prescriber. From Peter Mogari saying, thank you for the wonderful presentation. Should we also have good ambassadors to advocate for legible and written prescriptions from clinicians for better management of clients, for better management of clients and patients, and to avoid medication error? So I just wanted to ask you briefly. We saw the biggest percent, I think almost 47% of the errors from KNH are prescription errors. So is it an issue with the writing? Is it an issue with the knowledge? We don't know the doses and we are underdosing or overdosing the clients? Or what exactly is the problem? Why having so many prescribing or prescription errors?
Okay, thank you, Dr. Like I said at the start, when we see we have many prescribers, it does not mean our prescribers have a problem. It's that those are the errors that you can capture easily from documentation, because a prescription will be written somewhere, but the dispensing error is not going to be written, it's going to be done. The administration error is an activity, it's going to be done. So we also have now, we have either dispensing or administration error because the handwriting is illegible. I agree with the one who was asking now, we need ambassadors for good handwriting. I think there's one pharmacy awareness week where I posted in a group for in KNH that the best present that I think can be given during that week is to get prescriptions that we can actually read. So it's a challenge, true, but we need to just keep communicating. Sometimes we send the prescription back, please print. Occasionally even find the prescriber can't remember what they were trying to write. So they try to figure out what was the patient suffering from, so that you figure out backwards what were they planning to write. But it's communication. You need to send back and say, I cannot see this, please print, or call. If you are able to call, I think there's a Nikla pharmacy which is able to get back with the prescriber. If you build a good relationship, actually everything stems from how well you interact with the rest of the healthcare team. If you build good relationship, you can call. Sometimes if I don't find, if I can't trace the prescriber in that the actual prescriber, I will look for maybe somebody in that field and ask them what with WhatsApp, you share the prescription and ask them, this one has come from maybe iClinic and we can't seem to tell what is this that's being written. So the other ophthalmology will tell you probably they were thinking of this item, or they can manage to identify that scribble, whose handwriting it was, and then they get in touch with that doctor and now be able to feed back to us what it is that they had wanted to write. But if you don't if you don't tell somebody, I cannot read what you're writing, they will never know that they need to write it correctly. So even also encourage the patient, okay, now here I cannot see. You even sometimes ask them, can you actually read your own name in the prescription? So make sure when you leave the doctor, if you can read your own name, chances are you can read the prescription itself, because we see the handwriting will be the same. So why it is we're capturing many prescribing errors is not because our prescribers are the ones who are the problem only. It is because their errors can be documented. It's like an architect. His mistakes are there, you can see it there very clearly. It is built, you can see it. So now for us, the prescribers are the ones it is easy to identify theirs. But our errors for dispensing and administration, somebody has to observe them to know that we have made a mistake. And so now that can give you a false sense of security, assuming that we don't make any mistakes. But it's because someone actually has to observe that we have made that mistake and also report it. We've had clinicians who take pictures of maybe a prescription that was issued labeled wrongly and they WhatsApp it to us. So if they don't report it themselves, even ourselves, we need to take it up, we report it. We have received it as a secondary report, we report it so that we can build what are the dispensing errors we have found. And now for us, when we identify many of our dispensing errors relate to medicines looking alike, now we put in a system to reduce that. We put in the label so that we are on alert that, these medicines looks alike. But we need to learn to also tell on ourselves. So that's why we were saying, having the culture where we encourage each other to say, okay, I made a mistake. Even when I make a dispensing error myself, I document it because I know it will help somebody else, even if it's another intern who comes to the institution, but I document the mistake that I made. Don't say that this one is the boss of the area. You cannot document their mistakes. So it's just a matter of communication and encouraging each other to just report. Yeah, basically. If you don't report, we don't learn. Thank you. I hope I've answered the question.
Okay. Yes. Thank you very much. Thank you for that. Sorry, Annette, I'm seeing you asking a question about blood allergic reactions after transfusion. Allow us to address your question when you're having a conversation about blood safety later on in the week or sometime next week. So allow us to shelve your question for now for the next session. There's a comment from Dr. Octoria, and she's saying allergic reactions are adverse drug reactions, but not all adverse drug reactions are allergy. Thank you for that. There's a question from Kandiye Keluan, and he's asking whether you have a drug administration policy which can ensure drug reconciliation, especially in KNH. Do we have a drug administration policy?
Okay, I'm not too sure what a drug administration policy means, but I can tell you the policies we have. We have developed a prescribing policy that was presented to management for adoption of how it is prescriptions need to be done and what guides prescribing and the like now adherence to laws, like how you should prescribe narcotics and document. We also have now, I don't know whether it is the MTM service that we started and want to progress it further, where we look at, you try to intercept the point when the patient has already seen the clinician, review what is in the prescription before they go to pharmacy so that you can identify what problems might occur, so that you're not trying to identify the problem at the counter in the pharmacy. You identify it before the patient goes to pharmacy so that it's resolved. Then they go to pharmacy with a prescription which we can say is basically cleared. All issues have been identified. So I don't know whether that answers your question for the drug policy. Maybe you could make it a bit clearer, but that's what we have in place.
Okay, thank you very much. There's a question from Joan Kagame, and she's asking, what are you doing about anti-conversion and the change of brands and their impact to the patients? Is it a common problem? Are we having brand names changing or the brands changing frequently, maybe due to supply issues, or maybe it's out of production in the country of origin? And does it differ so much from the original prescription that the patient was having or taking?
Okay, thank you, Kagema. There are those medicines that we've identified as a division of pharmacy that we need to stick to the same brands because to ensure that the patient has the same outcome. But there are times when our hands would be tied in terms of we cannot get that particular item, and so you need to move to the next supplier. Also, our prescribing is you base it on the we say the generic name. You base it on the non-proprietary, the international INN, international non-proprietary name. But we have identified cases like for in terms of insulin, now the Mixtard and the sodium valproate, where we find when we switched brands, then the outcomes for the patients were poor. But you see, now you can't tell this without data. You need to get people reporting, you see, we are noticing this change, so that now that advises us what do we need to do to make sure that our patient get the best outcome. But we can't say that we will only buy a particular brand unless we have something to back up why it is we need that brand. We need evidence. We need basically you to report that the patient is not doing well so that we can do something about it. But if you don't report, then we are in the dark and we are unable to act.
Thank you for that. This is from Professor Oran. She's saying counter-checking is very important. That is true. There's a comment from one of the participants who's saying the presentation is awesome, but a point of concern to minimize these errors, apart from double checking, poor handwriting, which is common, and also the frequency on how the patient needs to take the medication. For example, if we write, I'm assuming that's metronidazole, although it's written metanidazole 1 times 3, this mostly makes more patients to mess up. Yeah. Any comment on that, Dr. Iwak? And still in the same breath, there's a comment from Naisi Poi, and she's saying prescribers should be prescribing in caps and use the molecular names to curb poor handwriting. Who will be our ambassador? Will that help if we write in capital letters and avoid abbreviations? Explain it instead of writing 1 times 3, actually write it in writing. We're telling you to take 1 tablet 3 times a day. Will that help in reducing medication errors?
Thank you. I think that is even an ambassador who has already spoken, and I hope they are also talking to others in their facility. But I think this is one opportunity, and we could also take advantage of this Patient Safety Week to be able to emphasize that message. If they could write in caps, it would be good. For me, at least if it is visible. it would be a very good step. And now for the 1 times 3, I remember, okay, usually when I'm supervising, if I'm supervising interns, I keep telling them, we discourage giving patients mathematical problems to go solving at home. So don't tell them 1 times 3. In fact, it's just easier to split the 8 hours. You tell them 7 a.m., 3 p.m., and 11 or at bedtime, so that now they understand. So I prefer when I'm labeling, I think even sometimes my colleagues will find that I'll make now the dispensing slower, because I'd rather write the time than write the 1 times 3. I'd rather tell you take at 9 a.m., 9 p.m. instead of 1 times 2, because people take 1 times 2 to be breakfast and lunch, or lunch and dinner. So I'd rather tell you 9 a.m., 9 p.m., 7 a.m., 7 p.m., 7 a.m., 3 p.m., 11 p.m., or like that. You know, you try figure out in terms of the time. So how it is you dispense. So don't be in a hurry. Mama, meza moja mara tatu, which is what we tend to do, especially when we see the queue is long. So I'm hoping that now that we know that patients can interpret poorly, we need to communicate. As all these things actually bounce back to communication. We need to take time and communicate clearly, and even have the patient verbalize back how it is they have understood the instructions, or when it is they plan to take. Other times you can even give them the pack with the instruction and tell them, so what time are you going to take? Instead of the way we are so used to telling them, hii meza moja mara mbili, or take this 1 times 2. You can ask them, what time are you going to take? You're supposed to take this every 12 hours. What time are you going to take? You see, now you make the patient a partner in terms of in the healthcare.
Thank you, and I like that. Make the patient a partner in their care. And when you talk about the 5 hours, one of them was the right time. So once you specify the time to the patient, it becomes easier. Otherwise, if you tell me to take 1 tablet twice a day, the variation or the duration will be different. Today I'll take at 7 p.m. because that's the time I remember. Next time I'll wake up at midnight and take it. There's and I take this as a final question due to time, although I'm still seeing more questions and comments coming in. And this is from Judy Maua. Judy is saying, who bears the cost of errors in medication, especially where patients stay in the hospital, where the patient stay and in the hospital is extended? Will it be the hospital or the patient? And that's a controversial question, because let's not just look at it from medication errors. Even if an error occurs during surgery, an error occurs during the care of a patient acquires hospital-acquired infection while still in the hospital, who should bear the burden of that cost? I think it's a very controversial question. I don't know, maybe Dr. Iwak, you have an answer, but for us from Patient Safety Unit, we've never been able to have to get an answer to that due to assistance. But you find in some of the developed countries, the hospital bears the cost for that extended stay. The hospital can even go to the patient can go to the extent of suing the hospital because of delayed care or extended stay and psychological trauma and physical and suffering. For whatever reason, they can actually sue the hospital or the clinician that was attending to them. And in some developed countries also, you find that the insurance company uses errors, medical errors, clinical errors, medication errors as a marker for the kind of reimbursement that they give the facility. So if we say the patient will stay in hospital for 3 days, but the patient extends their stay because they acquired an hospital-acquired infection and end up staying for 10 days, then the insurance company will use that as a marker for the quality of care, or to gauge the quality of care that the facility gives. So Dr. Iwak, in your opinion, and this being the last question, who should bear the cost of medication error to the patient?
And to think that if we start looking at who needs to be punished for the medication error, then now that means we are going to beat trying to build the patient safety culture, because we want to adopt a non-punitive approach. Otherwise, people will be scared to report an error. So I think if we go the way of looking at who do I punish, let's understand that in the healthcare system, that there's a chance that you could be exposed to an error. So the important thing is, what will we do to avoid that error from happening again? So if we hide, if people don't tell us what error they made, then we're not going to learn from it, and then we'll not put a system in place to avoid it in future. So I would, I know in the West, then they would rate a facility in terms of the errors, but I would say we need to be at a place where we should not be scared to err is human. Not saying that no one comes to KNH saying they are going to make an error. But when it happens, we need to be able to find a way of being able to do a root cause analysis and also communicate to the patient that unfortunately this could have happened because of 1, 2, 3 things. No unintended harm to get to you as a result. This is what we're going to do to mitigate against it. If it is that we are able to maybe waive some cost, but I don't want to say that we are going to punish somebody for that, because it will kill the whole patient safety agenda. So we understand, we come here, none of us intends to make a mistake, but a mistake is likely to happen. So the important thing is, what are we doing to make sure that that does not happen again? So we say that it will be a never again event. But if we look at in terms of how to punish, then now the 3 things I was taking at the end, the organization culture that we're trying to build of reporting, we will kill that. And then now in that case, we'll be exposing patients to harm.
That's true. Thank you very much for that response. And I agree with you, we'll be killing that organizational culture. You talked about 3 things: communication, leadership, organizational culture being the key drivers of patient safety in our facilities. Now I'm seeing 4 participants who've raised their hand. If you've raised your hand and you have a burning question or a comment or feedback to the presenter, just unmute yourself and give us your feedback. Otherwise, you're coming to the end of our session. So let's wait for people to unmute themselves and ask or give their feedback. I'd like to thank Dr. Dorothy Awak for taking time to come and talk to us about medication errors. Some of these things they look very small and we overlook them occasionally. But we're going to an era whereby the patient is more informed, the patient is aware, the patient needs to know. And also for us to learn from our mistakes that occur in the course of our work environment or as we do our day-to-day duties. So it is a learning opportunity for us. It is an opportunity to build up good and trustworthy systems that any patient will be able to advocate for them. So we thank you for taking time to come and take us through that. And before I let Dr. Awak make the final remark or final comment, and I hope Dr. Awak will come back again to talk to us about antimicrobial stewardship. And I've seen a comment on polypharmacy. So, so I really hope we'll be able to get to hear from you again. We really enjoyed this session. Now, for the people asking about the presentation, we will, with the presenter's permission, we will upload it to the KNH website. You'll be able to access it from there. Now, let's go to the CPD issue, because I've seen it's been quite a challenge to most of us. Now, I'll start with the doctors and the pharmacists. The doctors and the pharmacists, I hope you've been getting your CPDs on time. Before I let Dr. Awak make a comment on it, the systems were streamlined and you should be able to get your tokens. Although I'm seeing there's a comment from somebody who said they put in their token and it said it was invalid or expired. So I'll seek a clarification on the validity. How long is the token valid? This is from Francis. He said, I've tried to claim my points as per the emails I received, but the response is that it's either invalid or expired. Francis, give me time to find out about that, whether there's a time frame in which they expire. But I know for the doctors, it lasts for a bit longer. You can reclaim it at any point. I'll find out about the token system for the pharmacist. For the nurses, Rose Njoroge has written very clearly that for nurses CPDs, they're still following with Nursing Council of Kenya for accreditation. We're almost there. Once the process is over, we shall let you know. Thank you, Rose Njoroge, for the effort that you're putting in this venture. We appreciate you and we appreciate the energy that you have. Joseph Kuto from Clinical Officer is a member of the Clinical Officer Council. Joseph, we've still not been able to get accreditation with the Clinical Officer Council of Kenya, but I'm seeing you're saying you're in Kitale and you cannot travel for the signing of the book. Kindly let us know on email whether a letter would suffice. Let us know whether that is acceptable or the council will still have challenges with that. Yes, so Dr. Awak, would you like to comment something? And for those who are saying you've not received your tokens, also remember that Daktari Online, as they issue out the CPD points, they are following the process that has been laid out by PPB. So there's a system that you have to first register, you have to subscribe, through the PPB portal, but Dr. Iwak will take us through that, and you have to have attended the session for a particular amount of time. So Dr. Iwak, please clarify on that if possible.
Okay, thank you. I'm hoping that after this clarification, it will be fairly clear. So if I start with what is the process of how you claim the points? You need to have subscribed to the event on the portal. And then now you go to the, when we have attended, and you need to have attended at least 30 minutes, then now you'll be on the list that will receive the points. Now, in the past, why haven't you been able to get the points? I'd say, for example, for some people, you appear as a device. Like there's somebody who's here, Nokia 4.2. When you appear as a device, we don't know who you are. So, but now with the new token system, at least we can send to that email that you are appearing as. But before, when we had to go and actually look for your name, we didn't get people, because when you sign in, if you don't check your name, you're actually appearing as the devices that you're following the session on, and that brings a challenge. Secondly, it could be that you did not subscribe to the event. So now when you want to go and claim the token, you actually had not subscribed to that event before, so it does not appear. And then there's also a challenge. You might be putting a token in the wrong event. Each event has an event ID. So if you put the token on the wrong event, it will not go through. Each event has a unique token ID. And for those there are those who also would experience, maybe you load your tokens and it says expired or invalid, depending on the time when you did that, because at some point the PPB was doing some upgrades to its system. So it could have failed, but otherwise we have been assured that the tokens are going to expire on 31st December. And for those who have a problem, we've been reaching out to Mr. Murimi of the Pharmacy and Poisons Board. So I will ask him which email address we can reach him on. If you have such a problem, you need to screenshot it, and then I will, if it's not today, then tomorrow, we will send the email that you need to send, that you take a screenshot of that, because for some people there's a problem maybe either with your account or the like, and so you are not able to actually claim your points. But otherwise, the tokens, they are valid for until, we are told they are valid until 31st, but also if they're doing something on the system, if they're doing a system upgrade, you're going to have a challenge claiming those points. One of the other questions we're having is some events are not on the portal. Yes, we had a discussion with the board, and it was agreed that we are not going to be having like before it had been challenging to put all the events on the portal. So we have very many CPD providers providing events. So KNH will commit to itself to be putting at least 2 events in a week. That is, it's reasonable, it's manageable for us also to be able to manage the token system. Again, I have to say for KNH, we actually don't have, like we say, staff who are sitting to do the tokens. The CPD team are staff who are working in the pharmacy, so they will come, take care of the patients, and meet the pharmacy needs. And depending on the season, like particularly our June is usually quite a very busy season, so we're not able to be on time with that, loading those points, as we're looking for something that is more user-friendly, like sending the tokens through Daktari Online. If you've not been getting them, you need to check, because sometimes that can get to your spam folder. You need to know that when they're sending the mass emails, there's a chance for your email to pick that as and it goes to the spam folder. So you go to your spam folder and see if you have an email from CPD Pharmacy KNH. Your tokens might be landing there. So if you have a challenge being able to claim either you don't see the points, then it might be going to a spam folder, or the token says it's invalid. I will just sorry, both pharmacies and PharmTechs get the points. Now to clarify, the KNH CPD team has both pharmacies and PharmTechs represented. This is a hospital which is multi-cadre. So we have both pharmacies and PharmTechs represented. So there's no, like saying points only go to one cadre. We have the 2. The one who loads our events is actually a PharmTech. Then we have arranged three pharmacies and PharmTechs who approve the points, but now we are utilizing Daktari Online. I want to, in terms of presentation, it's free for the research and programs to share. I think most of okay, now Nokia 4.2 says he's Edward, but now the challenge you've been giving us, especially in the past, before we started using the token system, is that we could never know who you were. So for the much earlier ones, we can only do what will be humanly possible to be able to send you the points. But I hope that with time you will not. So if you can't see them, maybe check your email. It might be going to spam folder. Or also, again, remember, if we did not capture if it was much earlier, the presentations that were there before the token system was introduced after July, then we probably don't know what your actual name is. Maybe when we were giving your names on the chat box, you did not say who you were. You just appeared as a device. So you may not get points for those ones much earlier, but going forward, we are hoping that, and we are thankful to Dr. Online to be able to support us in that. But going forward, it'll be easier to get the points. Thank you.
Thank you, Dr. Iwak. And another challenge we've experienced is people logging in with their colleague's device. So, for example, if I'm logging in with Dr. Iwak's device, the points will go to Dr. Iwak. But I used her device to log in, maybe a computer, or she'd logged in and we were listening, all of us. So that's why we also have a challenge. And Bernard Oloch, we will send you the link. I'm saying you're using a device with a different name from your email address. So I really hope you won't have challenges getting the CPD points, especially if you've listened in to today's session. But high probability they will go to Samuel's device or Samuel's account, not your email account. So those are some of the challenges we've been experiencing, where you use another person's name to log in, either a colleague, a friend, but that's what the device, that's what our records read as. So we don't get your name in the system. So that's another challenge. So I'd urge you to all log in using your device. You could log in using your phone, you could log in using your laptop, desktop, but please use a device that has your name, that is recognized. Or even if you're using somebody else's device, please change the name if possible. Change the name to your name so that we can be able to get your details. But also remember, even if you change the name, the email address is still the other person's email address. So just log in using your own account or your own email if possible for ease of disbursement of the CPD points. I'd like to thank all of you for attending this session. We apologize, we are 12 minutes over time, but we really needed to have a conversation about the CPD points, and I really hope you've been able to understand what happens behind the scenes. We'd also like to thank the team from pharmacy who've been very instrumental in issuing CPD points previously. They were doing it manually. So once they finish their work, attending to the clients, once they finish reconciling whatever they need to do, their reports, then now they'd start the activity of manually and physically going through every webinar that was attended, looking for the pharmacist and pharmaceutical technologist and going through that system of issuing them CPD points. So thank you for the effort, thank you for the energy, and thank you for assisting us in that area. We appreciate very much, and we hope going forward we will have a smooth system for members of PPB. They'll be able to access their tokens without a lot of difficulty. So Dr. Iwak, final remarks as we end this session?
Thank you all for your attention and even your kind questions. And I just want to encourage us, let's go out there, communicate effectively, build the culture of patient safety, and be leaders in whatever spheres that we are, so that we can be able to be the change we want to see.
Thank you very much. Yes, let's be the change that we want to see. And remember the three things that Dr. Iwak said were very crucial for patient safety: communication, leadership, organizational culture. From Nasipoi, she's saying, thank you. You are the best. Yes, Dr. Iwak, you are the best. Thank you for that. And thank you for appreciating our presenters. It's not an easy task to actually talk to 500 people, faceless people. You can't see their faces, but some you can recognize are your seniors, some you can recognize are your colleagues, some you can recognize are your workmates. It is not easy dispersing that kind of knowledge and confidently and effectively the way Dr. Iwak has done. So we appreciate you for that. We look forward to seeing you tomorrow as we discuss health worker safety. Kindly share the link with your colleagues. sensitize them. This is not strictly to pharmacists, but this is to everyone, so that we also understand about health worker safety. So this will be from the KNH Occupational Safety and Healthy Committee and Health Committee. And I'd love to hear whether you have OSH committees in your workplaces. Kindly let us know. Do you have an OSH committee in your workplaces? That will be the conversation that we'll be having tomorrow. Are you able to report needle stick injuries? Are you able to report if you get TB while attending to your patient? If you get, God forbid, HIV due to a needle stick injury, do you have systems where the hospital or the facility is able to take care of you? And not even just that, any injury that you sustain, if you fall, if you slide and fall while administering care or giving patient care, is the hospital able to compensate you? Have you ever been compensated previously due to an injury sustained at the workplace? So that is a conversation we'll be having tomorrow during the health worker safety webinar. So see you tomorrow, and we're excited to have you there. Bye.